Welcome to Part 2 of Adverse Events, Assessment and Documentation. My name is Liz Ness, and I'm the Director of the Office of Education and Compliance in the Center for Cancer Research at the National Cancer Institute. Assessment of adverse events and timely documentation is crucial to research participant safety and a critical component of good clinical practice. At the end of Part 2, I hope you'll be able to describe the components of a quality adverse event assessment and documentation, as well as the common data elements that are collected on an adverse event case report form. When you are assessing safety and/or toxicity in a clinical trial, you need to first assess and document how the participant is doing at baseline before beginning any component of the research. So you want to assess the signs and symptoms that are present when the participant starts treatment. So for example, this could be the first day immediately pre-dosing or receiving the intervention. It usually doesn't include those signs and symptoms that occurred and resolved between the time of eligibility screening and the starting of dosing. Those often are considered part of medical history and are added to a medical history case report form. And you would need to have some type of a description such that you knew how severe that baseline symptom was. Please note, though, that some sponsors required the research teams to record adverse events from when the patient signs the consent through the first study intervention. This should be defined in the protocol or at least in the case report form instruction manual. Assessment of an adverse event is done by the principal investigator or their designee, who is a member of the research team. Typically, these are other licensed individuals. And it includes determining the severity as well as the cause of the event. It is this assessment plus the expectedness and outcome of the event that determine the timelines for reporting an adverse event to the IRB, sponsor, or other regulatory or oversight groups. The reporting will be done in AE Parts 3 and Part 4. Using controlled vocabularies to represent clinical concepts is the best way to describe an adverse event or to select an adverse event term. Medra, or the Medical Dictionary for Regulatory Activities, and SNOMED, or the Systematized Nomenclature of Medicine Clinical Terms, are two most common sources for medical terminology. Medra is widely used in clinical trials, whereas SNOMED clinical terms is used for clinical care data, often in your maybe electronic health record. In oncology, the common toxicity, the CTCAE, or the common terminology criteria for adverse events, is used, which is a combination of Medra terms, which we'll talk more about in a minute, and a severity rating scale, which will be described later in this session. Though the CTCAE was initiated in oncology, other disease specialties do use this as well for their standard in determining an AE term or severity, or use it as a model to create a similar type of severity rating scale. So Medra is a clinically validated international medical terminology dictionary, with each term having a unique code and what is referred to as a concept ID. Was initially developed in 1994 by ICH to facilitate the sharing of regulatory information internationally. Medra is used by the biopharmaceutical industry and regulatory authorities for AE classification. The structure of Medra is actually very logical. There are 5 levels to the Medra hierarchy, arranged from very specific to very general, or very general to very specific. The first highest level is called a SOC, or a system organ class, for which they're in the version of 26 that was released in March of 2023. There are 27 SOCs. These are the highest level of the terminology, and they're distinguished by anatomic or physiological systems, such as infections or infestations, or purposes such as surgical or medical. Then there is a high-level group term, a subordinate to the SOC, a high-level term, which is subordinate to the term above, the high-level group term, a preferred term, which represents a single medical concept, and then a lowest level term, which is related to a single preferred term as synonyms or quasi-synonyms. And here is an example of the preferred term fatigue, which is found in the system organ class of general disorders and administrative site conditions, a high-level group term of general systems disorders, NEC, or not elsewhere classified, a high-level term of asthenic conditions, preferred term of fatigue. And then when you look at the various lower level terms, you can see that these often represent how our research participants might express an adverse event term of fatigue, such as, I'm feeling washed out, I'm just tired all the time, I feel very weary, I'm exhausted. And that's then how we can take what the research participant says, what we see documented in a medical record, and determine what might be the most appropriate, let's say, preferred term that can be used and then shared across regulatory agencies. So understanding and measuring severity is also important. So in clinical trials, typically there are rating scales that are used to measure severity. The severity of an AE often determines if dosing interruptions, modifications, or maybe even a discontinuation needs to be implemented according to what the protocol says. Rating scales can be used for eligibility criteria. They can also include how the severity of the adverse event is to be measured, even if only providing descriptions for mild, moderate, or severe. And here you can see some definitions of mild, moderate, and severe. So mild, there is an awareness of a sign, a symptom, or an adverse event, but it's easily tolerated. Moderate means that it's uncomfortable, that it's causing some interference with usual activities of daily living, or that it may warrant some additional investigation. And severe is incapacitating their ability to do their usual activities or having significant effect on their clinical status that further warrants intervention. And sometimes, you know, my definition of mild might be different than your definition of mild. So it is important to try to hone in on this in a protocol when defining what severity an adverse event is. As I mentioned, in oncology, we utilize what we call the CTCAE. The National Cancer Institute Cancer Therapy Evaluation Program actually developed the original CTC, which was Common Toxicity Criteria, in 1983 to help aid in recognizing and assessing the severity, or what's referred to as grading, of adverse effects on chemotherapy. The name was changed since, as I mentioned in part 1 of adverse events, toxicity has an implication of an association with the intervention. And as we know, adverse events do not have that association. These became fundamentally agreed upon terms for adverse events within oncology research, but as I mentioned, it has gone to other disciplines as well. And it's organized by Medra terms using the system organ class minus the product issue system organ classification. And the AE term is a lowest level term, which can be rolled up then to a preferred term. This is just a brief evolution of CTCAE. Initially, there were categories and adverse event terms. You can see with each version, there were an increase in categories, which with version 4 in 2010 was harmonized with Medra's system organ class. And then the AE terms have also exponentially grown. You'll notice that the current version, 5.0, has 837 adverse event terms. And as you saw in a couple of slides previously, the Medra lower level terms, there were, almost 88,000. So these are certainly subsets of what is commonly seen in oncology research. I will note, as of this taping as well, version 6 is in the works and is waiting for finalization with the fall release of Medra, which typically is in September. They do sort of a 0.1 version release in the fall, with their main version releases in the early spring, typically in March. If a condition is not listed, since there's only 837 terms, each of the SOCs has what we refer to as an other category, so that a term can be applied there. And I'll show you how you would then determine what severity rating. But let's take a look of an AE term. I selected anemia. It falls within the blood and lymphatic system disorder SOC. And the SOCs in general are located alphabetically, and the adverse event terms also are listed alphabetically within a SOC. And as I mentioned, each SOC has an other AE term. All of the AE terms have a definition that you see here, as well as different grades. So when you read, when you're reading CTCAE, semicolons are read as or statements, and sometimes you will see what's called an M dash or a line, which indicates that that grade or that severity rating is not appropriate. For an example of then how to use this in reviewing a lab result, if you have a hemoglobin of 8.1, but the physician feels, based on the symptoms of the participant, that they need a blood transfusion, at face value, the lab value itself looks like it would mean that that would be a grade 2 event. However, when a transfusion is indicated, the comma or the semicolon in grade 3 reads as an or statement. So, or a transfusion indicated. So a hemoglobin of 8.1 with a participant who might be symptomatic and is in need of a transfusion becomes a grade 3 anemia as an adverse event. Here is another example, and I chose this example of diarrhea as an adverse event term to indicate how important baseline assessment really is. So you can see the SOC here of gastrointestinal disorders. And you can see that the grading or the definitions within each grade talk about an increase over baseline. So it's really critical to understand what the normal bowel pattern is of a research participant, especially when you may anticipate changes in their bowel pattern, given what you know about the products or the interventions within that clinical trial. You can also notice here that you have an increase or limiting self-care ADLs. So self-care ADLs are those ADLs that you do for yourself, such as bathing, feeding. And then there's other ADLs called instrumental ADLs that are part of some of the definitions. And I think of those as when you're not able to do for others, such as going to the grocery store or preparing a meal for your family. So since not all terms are available that are in Medra, other is an AE term, and then you describe that. And this is the descriptions for each of the grades here. And again, you would use the semicolons as an or statement. So if you had a term that wasn't available, you would look to the other grading scale and determine which definition or description it falls in to select the appropriate grade. So for those of you that do utilize CTCAE, it is available on a smartphone or tablet. It has a great easy search feature. This is just snapshots from the app from my phone. This pulls up the system organ class of blood and lymphatic system disorders. And when I went and plugged in anemia, you can see the same grading scale with the definition here that I noted in a few slides previously. There's also a PDF version on NCI's website, and that also, you can search using the PDF search feature. So the FDA also has a guidance document for grading adverse events in prevention clinical trials. And so you can see here they use a similar system of grades 1 through 4, and that is found in the guidance document entitled here on the slide. But regardless of how an adverse event is assessed for severity or which grading scale you use, the protocol ideally should help provide you with that information to guide you in having consistent assessments of severity rating. Once the severity of an adverse event is established, the next step really is to find the cause or the attribution of the event. Is the event related to the study agents, the patient's underlying condition that's being studied, or underlying pre-existing conditions? So determining the attribution is done by the PI or a provider designee who's knowledgeable about the product and about the protocol. I always think of determining an attribution or causality as not just a science, but an art. And here are some following things that can be some questions that you can ask to help the research team determine that attribution. What do you already know about the drug, the therapy, or the classification of the drug? So the expectedness. What is the temporal relationship of the event to the study therapy or intervention? Does the adverse event improve or disappear when the drug or the therapy is stopped? If the drug or therapy is reintroduced, does the adverse event reappear? Does it reappear at the same time point? Does it reappear at the same severity rating? Is the adverse event a result of signs or symptoms of the underlying disease being studied? Is it a worsening of baseline symptoms? Is the adverse event a result of an underlying concurrent medical condition or the use of a concurrent medication? So those are some questions. And so what are our options for then assigning those attributions or causalities? So there's sort of two approaches. This approach one is what I call the dichotomized approach. So you either think that it's related, so there's a reasonable causal relationship between the adverse event and I'll explain the blanks in a minute, or it's not related. There's no reasonable causal relationship. Then there's what I call the 5 degrees of separation, or 5 options, where you have definite, which means it's clearly related, probable, likely related, possible, may be related, unlikely, doubtfully related, or unrelated, clearly related. And the trick is really filling in the blank. So if the AE is related to the investigational product, the commercial agent, the underlying comorbid disease, when you fill in that blank, that will then help you to know if you have any reporting responsibilities to the IRB or to your sponsor, who in turn may then need to report to the IRB or to the FDA, my apologies. The IRB is looking at the relatedness to the research, so all components of the research, whereas the sponsor is often really looking for the relatedness to the product. So teasing this out is extremely important. And we always do want to tease out and try to determine how to fill in that blank and determine, is there a relatedness or not? And if the relatedness is to something else other than the research, we do owe it to our participants to determine that and to find out that cause. So when we start thinking about assessing of adverse events, it really comes from our participants, review of systems, physical exam findings, laboratory and other radiologic results, or, EKG results, things like that. But again, before starting on a clinical research study, especially a clinical trial, a good baseline assessment is needed. And that does include finding what is abnormal. So what laboratory values are already abnormal? In a review of systems, what are the current symptoms that an individual may be experiencing? It's also important to assess their concomitant or current medications, because sometimes a change in those, or if a medication was recently introduced, possibly a day before starting on an intervention, then the assessment might be a little bit different. So all of this baseline information is extremely critical. So adverse event information should be collected really, as I mentioned, from either the time of consent, if that's what the sponsor wants, or the initiation of the study intervention, or the start of a placebo lead-in period, or there may be an observational or washout type of period to establish what the baseline condition of the individual is, which is a little bit different than the baseline going in. There could be 2 baselines, if you will, if you have a placebo lead-in or some type of an observational period. So before documentation of an adverse event, the research team really does need to understand how AEs should be collected. In order to prevent bias, collection of adverse events, participants should not be questioned specifically regarding what we might anticipate could occur. So if we do know, for example, that there could be a change in bowel habits, we wouldn't want to necessarily say, have you experienced any diarrhea? Have you experienced constipation? But we would want to ask a general question of, have you had any changes in, your bowel pattern or your bowel habits? So that's really important. Ideally, the adverse events should be spontaneously reported or elicited from the participant during open-ended questioning, during the examination, or during the evaluation of the examination review of systems. Adverse events do need to be followed until resolution or stabilization. There are some adverse events that may never resolve. For example, with an oncology patient who has brain metastasis and receives brain radiation, the hair on their head, or alopecia, may not ever return. There's also some drugs that might have a toxicity of a neuropathy. That neuropathy may improve, but it may never be able to completely go away. So those are a couple of examples of sort of the stabilization, so further decreasing of severity, but not a total resolution. So all adverse events should be documented in a participant's medical record, or in some cases, for healthy volunteers, if a medical record is not required for the institution's policy, it may be documented in a research record, or potentially on a case report form, if that has been prearranged with the sponsor. The documentation includes, the adverse event itself, when it started, any workup or treatment that is needed. It is important that all healthcare providers, professionals who are interacting with the research participant, understands what is happening and what the research team, the PI, thinks the causality of the adverse event is. When that information isn't being shared, it could lead to the potential, treatment of the event with a medication that's prohibited on the protocol, or it could impact, another provider's ability to provide an accurate assessment and plan, if they're not a member of the research team directly. So a quality progress note documenting an adverse event does need to include the date of the adverse event. It also could be important to note the time, especially when dealing with infusion reactions. The time from the start of the infusion can be extremely helpful in further developing a product, and the timing of potentially the rate of infusion, as an example. Treatment for the event, and indicating if no treatment is needed, or further treatment, or an earlier repeat of a lab. Those are all examples of sort of a treatment. There should be a description of the adverse event such that it can be assessed for severity or graded depending upon the rating scale that is used. As I mentioned, the adverse event attribution is important to document, again, for other healthcare providers. And when the adverse event begins to resolve, worsen, or improve. So recording of adverse events, also known as data abstraction, is when we take what has been documented in the source document, the medical record or the research record, and we abstract that onto a case report form. And that is going to be dependent on the protocol. Some protocols may want all adverse events recorded. Others may only want grade 2 through 5 adverse events recorded, but the protocol should clearly outline what types of adverse events that have been documented need to be recorded on a case report form and used for further data analysis. Though adverse event case report forms can vary from institution or sponsor, most forms contain similar information. They contain what is the adverse event term, the date of the adverse event, the severity, the treatment, the attribution, and when the adverse event resolves, or when the grade of the adverse event ends and a new grade begins. So always refer to the protocol for these recording, what I call recording exceptions, and the case report form instruction manual. Both of those are going to be very helpful when it comes to then the documentation of the events in the research database or on the research case report form. So in closing, assessment of adverse events is critical for protecting our research participants and developing toxicity profiles for a drug or intervention. A quality baseline assessment is the first step in assessing an adverse event. Adverse event assessment includes asking open-ended questions as well as reviewing results from physical exams, laboratory, imaging reports, other medical reports. All adverse events should be documented in either the medical or research record, so all healthcare providers caring for the participant can be aware of the event as well as its cause. And the attribution of the adverse event should be assessed by the PI or provider designee and shouldn't be taken lightly. There are several questions that need to be addressed to achieve the most accurate attribution or causality of the event. While all adverse events are documented, not all adverse events may need to be recorded on the case report form, and even fewer will need to be reported to sponsors and regulatory authorities, which will be discussed in parts 3 and 4. So let's test your knowledge. The attribution of an adverse event can be determined by the study coordinator on the research team if they are a nurse. True or false? And the answer is false. The severity and relationship of an AE is completed by the PI or a provider coordinator, but not the study coordinator who may be a registered nurse. No matter how talented that coordinator is, the responsibility lies with the PI. Thank you for listening to part 2 of adverse events.